friends. Today is World Kidney Day, March 11, and March is the month of World Kidney Awareness. May sound new to some. WKD is what they call it. It's a global health campaign, which is spearheaded to create awareness about kidney diseases, and particularly about the impact and the frequency of the kidney disease. So every March, the second Thursday is when this day is celebrated. Currently, it is a declared holiday in 88 countries. And this has been spearheaded by the joint initiative of International Society of Nephrology, ISN, and International Federation of Kidney Foundation. Let me introduce to you today an eminent expert with a wealth of knowledge and experience in his field, none other than Professor Dr. Sanjay Aggarwal, currently the head of Department of Nephrology at All India Institute of Medical Sciences, popularly called as AIIMS in Delhi. Dr. Aggarwal is not just a dedicated clinician, but an academician, a researcher, all in one. Welcome to the show, Dr. Aggarwal.
Good evening.
Good evening, sir. I must share with my audience all about Dr. Sanjay Aggarwal, an FRCS, a Commonwealth Fellow, 15 fellowships in hand today, 17 orations down, a TTS champion in Southeast Asia region, a council member of International Society of Nephrology formerly, and currently Indian Society Nephrology and ISOT member of ISN ANIO Committee and ISN South Asian Regional Board, member Subject Committee, Expert Committee, Clinical Trials in India. And I can go on and on and on because it's an incredibly long list. But today, Dr. Aggarwal is invited on this panel to create awareness about the World Kidney Day. Lancet, a very popular, eminent, erstwhile journal, says that kidney diseases is currently accounting for nearly 10th highest number of the burdens of death worldwide. Sir, you are currently the chair of the Global Burden of the Disease in India, a CKD, that is Chronic Kidney Disease Expert Group. What is the kind of numbers that you see of kidney disease here in India and worldwide, and what are the difference in numbers and why?
You see, number one, that we should differentiate that every kidney disease is not chronic kidney disease. So once we talk of a chronic kidney disease, across the world, approximately 10% adult patient population of the world is having some degree of a chronic kidney disease. And we should understand that the chronic kidney disease has got different stages from mild to a advanced stage. And this 10% constitute all stages of chronic kidney disease.
True.
And the two most common causes are hypertension and diabetes. And we know that the magnitude of hypertension and diabetes is also varies from region to region in the world. So that contributes change in the percentage of the population who suffers from chronic kidney disease. These two are the major contributors in terms of a different magnitude of chronic kidney disease across the world. However, there are other factors also which causes change in the number of chronic kidney disease in the world.
So I am Dr. Puja Dewan and I'm a gynaecologist and I practice infertility IVF, and they say that 10% is the affliction of the burden of infertile couples, and quite similar to that, 10% in the least is the burden of hypertension, and what not to say about diabetes, which is the diabetic capital of the country, that is India. So yes, of course, with such a high prevalence of diabetes and hypertension, yes, of course, the kidney burden in our country is really high. But then, sir, they say that prevention is better than cure, isn't it? And how can really a layman be vigilant about the warning signs of this disease?
You see, the kidney disease, say management or handling of kidney disease in a society, we can go in three main stages. That number one, that we should see that the person does not develop chronic kidney disease. So there are action which a common person can do so that he does not develop chronic kidney disease. Second stage is that in spite of whatever we do, some of the persons will develop chronic kidney disease, and then we should make an attempt that in those patients, there should be an early diagnosis of chronic kidney disease so that the disease can be managed so well that person can lead a normal life. That what also is the theme of this year World Kidney Day, that living well with the kidney disease means you have got kidney disease, but don't get disheartened. There are management available that can make you reasonably fit to lead a normal life. And third, once you have made an early diagnosis, we do management in such a way that the person from early stage of chronic kidney disease to advanced stage, it either doesn't reach to advanced stage or at least it delays that stage when the person needs dialysis and kidney transplantation.
In fact, I will add to what Dr. Agarwal has very pertinently mentioned, that WKD every year, World Kidney Day every year has a theme. And the theme for 2021 is living well with kidney disease. And what we are really focusing at is the quality of life of not just the kidney disease patient, but also the attendants. So how does a kidney patient figure out effective symptom management at his own level? How does he know when to go and seek consultation? How does he as a patient get empowered by himself? How does he feel encouraged about live participation in day-to-day events, because he knows that he has a chronic kidney disease, he may need to have a dialysis, he may need to go in for a transplant follow-up, may have do's and don'ts and precautions to take. Keeping all those things in mind, particularly when we just had a pandemic very lately, and these are challenging times, what is it, sir, that you would really like to give away as a part of your advice to this theme?
So what this theme says, although every time theme is different, but every year on the background of the theme is prevention of chronic kidney disease. But this year theme is that if you develop chronic kidney disease, then if you contribute along with doctor in your own management, you can lead a reasonably good life and can contribute to the society and to your family. So maybe if we show our slides, then we can explain that how a common person can prevent development of kidney disease, how can he contribute in management of this disease.
And of course, also add to this fact that, sir, you are currently the president of the Institute of the Kidney Foundation and also honorary secretary of the Indian Academy of Nephrology. So I'm sure that in the slides which come ahead, our audience will also get a knowledge that what is it that a common man can do in daily life to keep the kidney disease at bay. And of course, what are the warning signs? What is the treatment? What is the management as a large picture on a cross-sectional view?
In handling of chronic kidney disease in any society, there are three major components. One is we should aim for prevent development of a kidney disease. And second one is that once we know that some of the persons will develop kidney disease, we should make an attempt for early diagnosis so that patient can be managed much early. And third component is that if person diagnosis has been made of chronic kidney disease, we should prevent further deterioration so that patient does not reach to the stage of requirement of dialysis and transplantation. Next slide. So for prevention of a chronic kidney disease, that somebody doesn't develop chronic kidney disease, these are the few steps which we as in, collectively can take. We should aim for a good antenatal care, and this is very important thing which many people may not find a very important, because in India 1/3 of the live delivery are low birth weight, and low birth weight child at a later stage has got a very high risk of development of a diabetes and high blood pressure. So by providing a good antenatal care, we can prevent low birth weight and future development of a diabetes and blood pressure. Every individual should do a regular exercise and prevent diabetes and obesity by regular exercise. One should use a balanced diet, and by balanced diet, they can prevent obesity and development of a high blood pressure. Everyone should take a adequate fluid, and what adequate fluid, we mean that an adult should take approximately 1.5 to 2 liters of fluid, because this will prevent concentrated urine, and we know that the urine is a source for excretion of waste product from the body, as well as the source of excretion of the product of various drugs which one takes. So by preventing concentration, we will prevent the damage to the kidney by toxins and the product of the drug. Another important component for prevention of kidney disease is that we should not take any medication on our own. This will prevent the drug-related kidney damages, which is an important cause for chronic kidney disease. And in India, it will be important to say that we should do yoga and meditation and prevent stress, which probably contribute to most of the diseases in the society. So these are the common things which, if one follow, he can prevent the initiation or the beginning of chronic kidney disease. Now in the next slide, we see that how the early diagnosis can be done if any person is having or developing chronic kidney disease. So may I have the next slide? Now, once we know that the two common causes of chronic kidney disease are diabetes and high blood pressure, so what diagnosis, for diagnosis of chronic kidney disease, we need two tests. One is in the urine for the protein, and one test in the blood, which we do for estimation of serum creatinine. Now, these two tests are very simple, involve very little cost, and can detect more than 90 to 95% patient of chronic kidney disease. Now, the point is that for early diagnosis, these two tests should be done. So the next question comes, which person should be subjected to these two tests for early diagnosis? So this slide shows that all diabetes and high blood pressure should be subjected to these tests every year. Anybody who has got a family member who has got kidney disease is also at a high risk. Any person who develops swelling over the legs, because kidney excrete excess water, so swelling on the leg is an indicator for chronic kidney disease. Then if someone is developing fracture with a minor trauma, and this is important because normal functioning kidney keeps the bone strength normal. So if anybody is developing fracture with minor trauma, there is a possibility that he might have a kidney disease. So we should do these tests. The next is, if anybody having low hemoglobin and we are not able to find the other common cause like nutrition, then we should do these tests, because normal kidney function maintain a normal hemoglobin in the body. So if kidney are diseased, the hemoglobin goes lower side. Anybody who crosses 60 years of age, they are also at a high risk. In addition to these high risk group, if any person has got a urinary complaint like difficulty in passing urine or blood or pus in urine, or there is a less amount of urine or more amount of urine, then all these things person should be tested for early diagnosis by these two simple tests. Now then, once we diagnose chronic kidney disease as early stage, our next important component is that we should prevent further progression of kidney disease to advanced stage. And may I have the next slide? Because these are the components which will prevent person to deteriorate from early stage to advanced stage of chronic kidney disease. And these are the components that person should have a very good control of diabetes and high blood pressure. Majority of patients of chronic kidney disease needs regular medication. So they should continue a regular medication and should get a regular follow-up. They should stop smoking if they are smoking. Diet and drugs in these patients are very important, and they should follow the doctor advice in relation to the diet and what drug they should not take and what drug they should change the doses, because kidney is source for excretion of the product of the drug. We should keep a positive attitude. What this year World Kidney Day motto is that there are treatment available and you can lead a normal life, and at some stage there should be early referral to nephrologists who can plan your treatment very well and you can lead a normal life. So these are the three important steps which if somebody follows, he can lead a normal life and prevent the kidney disease and the need of dialysis and kidney transplantation. What we say, save kidney and avoid dialysis and transplantation as a broad motto.
What you have mentioned, Dr. Agarwal, is most pertinent for the layman and the doctors to understand prevention, warning symptoms, regular follow-up, whatever is in your hand, and about, of course, properly managing your medication and focusing on quality of life and de-stressing. Now, I would like you to share what exactly is the difference between an acute injury to the kidney and a chronic kidney disease, and what is the difference in their recovery pattern as well as their long-term health on the kidney.
So you see, acute, as the term says, means that the kidney injury is or the kidney disease is developing within few days. And most of the time, acute kidney injury is potentially treatable completely. So there are patients who may develop severe acute kidney disease to the extent of requiring dialysis, but still they can become absolutely normal. Although in real situation, this does not happen. Severe type of acute kidney injury patient, some percentage, approximately 10 to 15% patient do not recover completely, and they go to the stage of chronic kidney disease. And that's what we say, that the patient who are discharged from the hospital with the diagnosis of acute kidney injury, they should actually be followed regularly in the outpatient, because we should see that which 10 to 15% patient actually out of acute kidney injury are developing chronic kidney disease, because then we can manage those patients from the beginning of the diagnosis of chronic kidney disease. As against acute kidney disease, once if we label a patient correctly on chronic kidney disease, he will unlikely to recover completely. And from a milder degree of chronic kidney disease, most of the time patient progresses to a further stages. Although as we discussed previously, if they are managed well and patient contribute in his own management, then the progression can be so slow that chronic kidney disease can remain stationary at one level for years to come. And it doesn't looks like that it is progressing. And that's what is actually our aim. And it is important to point out at this stage that the earlier we pick up the diagnosis of chronic kidney disease, we can contribute progression much more as compared to if we pick up the diagnosis of chronic kidney disease at a later stage. Because then the rapidity of progression of chronic kidney disease is much faster. So we can contribute in prevention of progression if we diagnose at an early stage much more than the late stage.
So there is, of course, hope that if you catch the disease early, you diagnose early, you manage early, there is hope that the progression to deterioration can be slower and can be somewhat in your hands through your inputs as a patient itself.
Yes, that's correct.
So I have read that you have certain fields of interest amongst the kidney diseases. One amongst them, of course, we've talked about CKD, we will talk about kidney transplantation, but amongst them there is also glomerulonephritis, tuberculosis. Would you like to say a few words about that?
You see, tuberculosis is very common, what we call as a latent tuberculosis in India. If we take India, 25% population in India has got latent tuberculosis, which means they have got tuberculosis bacteria in the body, but that does not manifest in the disease form. Now, any condition in which the body resistance goes down, then that latent tuberculosis develops into active form and patient becomes symptomatic, what we call as a case of tuberculosis. Now, chronic kidney disease is a condition which we call as a immunocompromised state. And because it is immunocompromised state and patient, when they go into dialysis and transplantation, this degree of immunosuppression increases further. So these patients are at a much higher risk of developing tuberculosis. So what we have shown that in dialysis and kidney transplant population, approximately 10 to 15% patient of chronic kidney disease develop tuberculosis. And we have shown that if we do some intervention in terms of a prevention, so in spite of having a latent tuberculosis, they do not develop in a case form or they do not develop active tuberculosis.
Right. And what about glomerulonephritis?
Now, after, as we were talking of causes of chronic kidney disease, and we discussed that the diabetes and transplantation are the two common causes of chronic kidney disease. Third common cause is glomerulonephritis. These are a group of diseases in which the one of the part of the kidney which is filtering component, which is glomerulus, it is basically, in a layman, you can say it is inflammation of the glomerulus, and because of that, if it is not treated properly, then these patients also land up into permanent damage of the glomerulus, which leads to chronic kidney disease.
Doctors often also have this question that there is urinary tract infection and there could be a fulminant form which goes up to pyelonephritis. A few words on that as well.
Now, there are, it's very probably in terms of a common person or maybe even internist and physician also, I often say that they should differentiate medical diseases of the kidney versus surgical diseases of the kidney. Now, medical diseases involve both the kidney and diffusely involved. So every part of the kidney is involved. While the surgical diseases often involve part of the kidney, maybe part of the one kidney or part of the both kidney. Urinary tract infection or pyelonephritis often involves one kidney.
Yes.
And we know that if one kidney is completely damaged, the person can lead a normal life on single functioning kidney. So likewise, cancer of the kidney or stone diseases of the kidney, these involves often single kidney. So although surgical diseases are causes symptom, they are picked up early, they causes morbidity, But because they often involve only single kidney or part of both kidney, they often, most of the time, do not lead to chronic kidney disease. So what you are saying that pyelonephritis acutely can cause acute kidney injury. But pyelonephritis, particularly acute pyelonephritis, is not a common cause for chronic kidney disease.
True, true. So as we move ahead, we know that in our country, nearly 4 lakh people are suffering with chronic kidney disease per year. Out of that, just about 8,000 odd of them do meet the needs of a kidney transplant. So there is a huge gap between the need, the supply, the demand. So, we are somehow, unfortunately, facing incidents like kidney rackets, kidney scams, which are flourishing around. What do you think is really the reason behind this?
You see, first I would like to do minor correction that now that 4 lakhs people requiring dialysis and transplant is not every year. It is at any time, any one time 4 lakhs people require. Every year is approximately 1.5 to 2 lakhs per new patient require kidney transplant. Now the problem is that the treatment of advanced stage of chronic kidney disease where the transplant is required, there are 2 types of treatment available. One is dialysis and other is transplantation. Somehow both the treatment are reasonably costly. For dialysis, there are deficiency in terms of facilities available across country, particularly in the rural area. Plus, cost of dialysis is significantly high. On an average, we can say approximately 25 to 30,000 rupees per month is the expense of dialysis. And we also know that the dialysis doesn't do anything in terms of a cure of chronic kidney disease. So dialysis goes on and on and on for rest of the life, which is not easy for any common middle class person to expend that much amount of money only on one single member of the family for rest of the life. After all, every family has to see the viability of the treatment and rest of the life of the rest of the family members also. So dialysis is the problem because of the cost and absence of or paucity of facilities in the rural area or suburban areas. We know that our Honorable Prime Minister has initiated a national dialysis program, and now the dialysis facilities are being available at a district level, and probably it might go up to the primary health center level also in times to come. So that remains aspect of the dialysis. On the side of the transplant, although transplant is approximately 50% cheaper in terms of a long-term expenses as compared to dialysis, for transplant we need a kidney. And kidney as of now cannot be manufactured in a laboratory. It has to come from a human being. And there it comes that for kidney transplant, in addition to the number of centers transplant in India, there is a major shortage of the organ donor who can donate a kidney. And we have learned in our previous discussion that the person can live on one kidney normally for the rest of the life. Because of this peculiarity, the issue of living donor transplant come into practice. That person can give a kidney and can live a normal life. Now, in my perception and in perception of most of the nephrologists, the person who is donating the kidney and which in media often is labeled as a racket, actually that person goes to so many tests before transplant that he is fully aware what he is doing. So you often read in the media that person, or the statement of the person comes that he was not aware and his kidney was taken without his consent or keeping him in dark, which is absolutely not possible. He undergoes so many tests which involve so many days, that it is not possible that he is not aware what he is doing. The problem actually comes that the middleman who comes in between, he promises certain amount of money to that donor who knows what he is doing. But after donating, he doesn't get that much amount of money which is promised by him to him by the middleman. And then the media comes into picture, and that person then comes to the media that my kidney was taken without my consent. It is actually he hasn't got the amount of money promised by the middleman. And all these things are actually still possible in our society and in many other society across the world, because the cadaver or the disease donor transplant is not very active or not very sufficient to fulfill the demand of the kidney required by the number of patients of advanced chronic kidney disease. And their roles comes for prevention of chronic kidney disease, and that is what the motto of World Kidney Day is, that if you prevent chronic kidney disease, you will decrease the number of the patient requiring transplant. So whatever facilities in country are available and whatever number of the disease donor are available, those will be sufficient to fulfill the demand, and the question of transplant racket or such type of a activity will not arise in any society. And that's what we are trying to do, that the number of disease donor transplants should increase, and simultaneously we should prevent the development of new cases of advanced chronic kidney disease. So both the things needs to go simultaneously to make this as a success story for handling the patient of chronic kidney disease in any society.
True, and of course we are all aware very well that 10% of the cadaveric donors and 90% of the live donors is generally the ratio when it comes to organ donation. Am I right?
Yes, that's correct.
Yeah, and so we did talk about people donating kidneys, and to the awareness that we have that a blood relative, a close relative, should be the ideal donor when, of course, matched and all the prerequisites fall into place, with, of course, rigorous counseling and legal documentation of consent. And then, of course, there is this slight gray zone which exists, that yes, there is a close relative, blood relative, but there can also be a close friend which has to be proven that it has a long standing of being a very close friend, long associate. And I think this is where the gray zone area comes and where these issues flourish.
Yes, you are correctly saying, but the reality is that this is already inbuilt in the Transplant Act of the country. Because we must realize, in current situation, in a practical point of view, if you see a 40-year male adult in the family and he develops chronic kidney disease, which is actually the commonest age, at least in a public sector hospital, of patient of chronic kidney disease. Now he has got a young wife, he's got children who are unfit because they will not be major. He will be having parents who will be crossing the age or may have age-related diseases like diabetes and hypertension, and they are also unfit.
Comorbidities.
Then comes the nuclear families nowadays. So that person may not have a number of siblings available who can donate. He might have a single brother or maybe one more sister who has got their own family, and their own family may not be agreeing to donate for the brother. So because of this, the law has inbuilt made a provision that somebody genuinely doesn't have a family member, then where he goes. And this is the time when the cadaver was not existing at all. This is 1994 when the law was made. So provision was made that suppose if somebody is working in the office for 20 years and if he is willing to donate to save the life of his colleague with whom he was working, so why not it should be. So all these are inbuilt provision in the law, and these type of cases which are not near relative goes through the various committees before the permission of transplant is done. So there are, I will not say that it is foolproof system. There are loopholes which people exploit. So that is why again we will come.
So similar and familiar to me, because I'm an IVF specialist, and when we talk about uterine surrogacy, and then when we also have progressed and developed laws, and this is how it was, that now if it's your blood relative, that person can only be a surrogate. Earlier it was that blood relative or anybody could have been. Then it said, no, not at all a blood relative, but someone else. And then it came back full circle saying that only your blood relative can be. And again, because of the reasons that you have stated, a close associate as a, provision has been brought in. So it used to be that they could pay for it, and then it's completely philanthropy now. So it's a full cycle that a country, a legislation, disease, disorders go through, isn't it?
Yeah, you see, very similar. There are discussion for years now that the person who is not near relative and friend or acquaintance in the office, whether he should be paid some money for donating. So the issue of paid donor is going on across the world for now maybe 2 decades, and some country has adopted in some form of the payment. But in our society, probably Act doesn't permit, because I personally feel our society is not that mature that we can justify payment for the donation of the life.
Moving on, sir, on 8th of March, incidentally, just 2 days before, was International Women's Day. And there was an oft remark by a prominent transplant surgeon in the country. And the person mentioned that, 80% of the donors happen to be women.
Yes, that's correct.
Is that the case with renal transplant as well?
Yeah, but you see, there are very obvious social basis of that. You see, initially when the 1994 Act was not there, and even after that also, if you ask who is the commonest donor, the answer is mother across the city.
Mother.
Because, I mean, we still say there is nobody who can replace position of mother in anybody's life.
I've been fortunate to work in quaternary care centers, and whenever there was a fitness from the gynae perspective, it was almost always the woman, and it was almost always the mother.
So if the son or daughter is not well, need a organ, it was mother who used to come first forward that she will give. And so many times we listen a statement that mother says कि चाहे मेरी life चली जाए, मेरा बच्चा ठीक होना चाहिए.
So moving on, sir, I think the society has progressed to some extent. We also have a couple donor swapping, don't we? That there is a couple, and one amongst them needs the kidney, and there's another couple, the other person also needs the kidney. But within that couple, the one who wants to donate, the parameters don't match, but match with another couple, and vice versa, and that's how it is.
Number one, there is a minor correction in this. Number one, this is not between the couple. This we call a swap transplant. And swap transplant is possible within the first degree relative. And in that, somehow, spouse doesn't come into picture. So it is between the two relative. And this swap transplant actually started because the catheter transplant was not very active. And there are medical reasons that whatever is small family and the family member are there, somehow because of the medical reasons, they are not able to donate the organ in spite of their willingness. And the two common causes of that was that the blood group was not matching in the family, and other was that the patient has got what we medically call antibody, or you can say there are substances in the patient body which will reject the kidney being given from a family member. So these two situations actually created the need of the swap transplant, that there are two pair, recipient and donor, and the other pair, recipient and donor, they themselves may not be able to donate to their own recipient, but they can donate to other person recipient and the vice versa. So this has given an increase in the number of the transplant, and in some of the center in India and across the world, swab transplant is constituting somewhere 20 to 30% of total transplant in particular hospital.
That is so positive. I feel.
We in All India Institute also have done swab transplant.
And I must share with the audience that Dr. Sanjay Aggarwal is the advisor to NATO, that is the National Organ and Tissue Transplant Organization. And of course, he works closely with the NATO registry as well. So, Dr. Aggarwal, where do we stand with regards to kidney organ donation and this legislation as on date?
So you see, after 1994, then the Act and rules under the Act were amended in 2011. Act was amended, and then 2014, some rules were revised. NATO was established in 2012, and the aim was, as under the Act, it was Act says that there should be a national body which should promote organ transplant and regulate organ transplant in India and maintain a nationwide registry. And with that, because that was the component of the Act, that the NATO was established under Director General of Health Services, Government of India. It is based in Safdarjung Hospital, and the primary aim was that under this national body, there will be a regional body, 5 regional body, what we'll call ROTO. As national, ROTO is the regional, and under each regional, there are state level organization. So it was a sort of a network which has been established, and slowly a good activity under NATO are happening under the ROTO, but basic unit is SOTO. So NATO is more of a advisory or policy making body and coordinating the organ transplant and keeping the registry, because registry is the important component which guide the change in the policy in relation to the transplant. Because once we know that 50,000 transplant has been done, we can analyze which one is good, which one is bad. So it can help in changing the policy at the level of the Government of India.
I see. And you are so heavily into research. You have 28 funded research projects which were conducted with you as the principal investigator, and 286, nearly 300 research publications. Could you share with us the study which is much talked about research project which you have been actively involved with, which is across 7 states and involves nearly 15,000 patients, which you have done along with the ICMR task force on kidney diseases?
Yes, you see, our institute, when I was the first study done by us was in city of Delhi only, magnitude of chronic kidney disease. That time it was only one city, and after that there are many such studies has been done for finding out magnitude of chronic kidney disease. But these are limited to the single center or single city. And we know with so much diversity in our country from one side to north to east to west, that a single center study may not actually generalize in terms of assessing the magnitude of problem. Say if we do in city of Delhi, we may not able to say that the same magnitude will be in Mumbai or in Calcutta or in Madras. So this was going on for so many years. Then ICMR thought of doing a task force study, which is a study which is ICMR initiated, and we did it for finding out magnitude of chronic kidney disease across India and selected 7 cities in different regions. And the study was completed last year. It is still being, manuscript is being prepared. And we covered 15,000 subjects in community-based study, which is actually the most scientific way of finding out a magnitude of any disease in the community.
Huge
And
power
also,
value to this study, I'm sure.
yeah,
Good
I mean, it
sample
involves
is huge power.
seven centers, 15,000 subjects, and we did with most scientific rigor this study and concluded that in common, if we combine all the 7 cities, 9.4% adult urban population has got chronic kidney disease. And we also concluded that the magnitude is not same in all the 7 cities. In some city it is more, in some city it is less.
And that's quite a number. And it is the sample size which impacts the wealth of the study and its robustness.
Definitely.
So as we move on, you are the editor-in-chief of Seminars in Dialysis, Indian Journal of Nephrology. You are, of course, associate editor in the Indian Journal of Transplantation and are editorial board member in 16 journals. So I guess, research kind of runs in your blood is what I would say. And you are in an institution which is also research-based. But over and above this, Dr. Agarwal, what is it that one feature as an editor you feel on this World Kidney Day is the most needed space to work upon to improve kidney care? That one feature where we need to research, which we need to bring forth to improve outcomes.
Probably a medical, simple, generic medication at an early stage of chronic kidney disease to prevent the progression of chronic kidney disease will be the key factor, because we know whatever we do, some percentage of population will develop chronic kidney disease. And if we can manage at an early stage with a simple, low-cost medication for preventing further progression and need of dialysis and transplantation, I think that will be the most crucial thing for managing magnitude of chronic kidney disease. We will never be able to manage chronic kidney disease by increasing the number of dialysis or increasing the number of transplant, because even most advanced countries fail to do that. And so our major emphasis must be on prevention and early diagnosis of chronic kidney disease with a cheaper generic medication. That will be the success story for managing as a society as a whole. Once we talk of a single patient management, I think I by no means saying that the dialysis and transplant is not required. But then that will impact a very small percentage of magnitude of chronic kidney disease. What will impact at a larger level is prevention and early treatment with a cheaper medicines available.
Yeah, drugs like erythropoietin continue to be expensive, not talking about immunosuppressants and others, and all the associated opportunistic infections which come up here and there.
So I will come to a issue once we were, if you compare the, our audience understand communicable diseases and the non-communicable diseases. And if you compare out of non-communicable diseases, we know that the heart disease, high blood pressure, stroke, and cancer, these are the diseases which are clubbed into non-communicable disease, and chronic kidney disease is one of them. Now, if you compare the cost of treatment of all these diseases, then probably cost of treatment of an average sample of chronic kidney disease is far more than the diabetes, than the heart disease, than the stroke or hypertension. And we often say that the treatment of chronic kidney disease is much more costly and complicated than even the cancer. Because in cancer, if it is early stage, cancer is cured. If it is late stage, then probably person doesn't survive. Now, chronic kidney disease is such that the treatment is costly, and treatment changes the life of the person to such a good level that he doesn't want to leave the treatment. And reality, he can't leave the treatment. So a single patient in a family of chronic kidney disease who needs dialysis and transplant, actually whole family revolves around that single patient. So in that sense, it consumes so much of the finances of the family that in our opinion, as a nephrologist, it is worse than the cancer.
Earlier, mostly the private centers had dialysis units. Now, lots of government institutions have proper dialysis units with huge number of beds. And of course, there are so many philanthropic centers which have also come up. How much do you think there has been a true shift in terms of availability and cost?
You see, government has, as I say, our Honorable Prime Minister has initiated national dialysis program, and every district is supposed to have a dialysis center with 6 dialysis machines. But see, one of the very important issue which is missing here is that these government centers provide free dialysis to a section of the society which is called below poverty line. Now there is a huge section which doesn't fall under below poverty line and which is not so well off to afford the dialysis. Now that section is not supported with these dialysis centers. So what I want to say that although these dialysis centers which are initiated by government help the below poverty line patient, but a large percentage of patients still remain out of purview of treatment from these centers.
True. So we do have some questions which have come up, and I think we should have a look at them. So I will read aloud the questions. Some of them can be a repetition, but before I shoot that question, safe motherhood, healthy mother, healthy child. The mothers can get afflicted with pregnancy-induced hypertension. There could be chronic hypertensives earlier. There could be an exacerbation of that condition leading to preeclampsia and eclampsia as well. And they may not progress to deterioration. Still, they could have a premature baby. They could have low birth weight. On the other hand, there is gestational diabetes. You could have been a diabetic earlier on, overt, covert, latent. You could also have become a diabetic during pregnancy. This can also affect the health of the baby. The mothers by themselves, even if it is purely pregnancy-induced hypertension, may recover post-pregnancy, and they may be gestational diabetic and may recover post-pregnancy. Yet, nearly to the tune of 1/3 of them can progress to hypertension and diabetes in the near future within 10 years as well. So they will be comparatively younger diabetics. So what kind of burden, you just made a mention that to have a baby which is born with low birth weight or preterm itself can be an early developer of a kidney disorder. Equally, we have this. And we are a young country. We are a young nation. 30% of, there's almost 70% of us, which is young. So what kind of numbers and loads are being added, and how do you think we will manage to deal with this? What about the budget allocation?
As compared to budget allocation of chronic kidney disease, I'm sure there is a far more budget allocation in mother and child. But still, in spite of that much allocation, currently, if I am correct, 1/3 live baby are low birth weight baby. Yeah. And these in future are at a much higher risk of developing diabetes and hypertension. So safe motherhood and care in antenatal period to avoid low birth weight baby will go a very long way in prevention of a future development of a patient of diabetes, hypertension and chronic kidney disease. So that is why when I was showing that for prevention of chronic kidney disease, my first component was that a good antenatal care and prevention of a low birth weight baby is one of the very important component in decreasing the magnitude of chronic kidney disease in any society.
So now, quick questions from the audience. Quick answers, short answers. So Dr. Jerin K has written that, what all troubles and failures have you gone through to reach your current state as a nephrologist?
I will say nephrology was not my first choice when I was doing MD, but because during MD my thesis was on a nephrology topic and my supervisor was a nephrologist, so I came into nephrology. In any field, whether it is nephrology, whether it is medical or non-medical, one has to work really hard to reach to the at some level, and I have no hesitation in saying when I joined All India Institute during that residency period, I did very hard work, which at the moment the new resident who join, we don't see that much passion in terms of a hard working and making the life for the future. Now, in every society, young people want very fast development of the career and very fast earning. So those things may not be very good for on a long-term basis.
Isn't it, Dr. Agarwal, that when we talk of our good old times, and it always brings us a smile on our face. And of course, you are from King George Medical University, college earlier, now University Lucknow, and alumnus of that. And as we move on, Dr. Sundar Murthy from Tamil Nadu has asked a question. Is there any absolute contraindication for calcium in osteoporosis patients?
No, in osteoporosis patient, calcium is not a contraindication, but how much calcium alone will help in preventing or management of osteoporosis, that is a controversial issue. And alone calcium will not be helpful. We need to add with vitamin D along with the calcium and other agents for osteoporosis. And I will say that rather than management of osteoporosis, we must stress much more in prevention of osteoporosis. And for that, during the younger age group, the good bone health, making a good calcium diet during the younger period, whatever bone strength we form up to the age of 25 to 30, that actually contribute much more in prevention of osteoporosis at a later stage.
True. So I don't have any further questions, but I would like to ask you a question from my side. And
Sure.
The question is, how do you see yourself, Dr. Agarwal, yourself and India, as a change maker in the field of kidney disease in the years to come?
So it is a loaded question. And
yourself and India as a change maker.
I think I will again say that in terms of a advancement of the new drugs related to kidney disease, probably it will not be easy for India to compete the Western world. But what we can definitely guide or project India in front of the Western world will be prevention and generic low-cost medicine treatment for patients of chronic kidney disease. In that, we can definitely contribute and show to the world that yes, in this area of chronic kidney disease, we are ahead of you.
And possibly we are such a big population, our number load and the numbers itself are so many that the database that we generate through aggregation and when presented can actually spearhead and formulate ideal treating methodologies.
Yes, that is also a factor because say the type of glomerular disease we do in All India Institute, say 800 biopsies, while 800 biopsy in any Western center will take 4-5 years to do. True. So we have got large number of the patient who can generate more authentic data in the research point of view.
So with this, on World Kidney Day, I wish everybody good health, good kidney health. And if we want to keep our kidney disease at bay, as per the experts, Dr. Agarwal here, I would just like to emphasize that you have to drink lots of water, you have to have healthy weight, you have to have healthy diet, you need to exercise, you need to manage your BP, you need to monitor your sugars, you need to be in touch with your doctor, you need to avoid unnecessary painkillers like NSAIDs, you need to reduce your stress. We are all very stressed out. You need to sleep well, and of course, quit addictions like smoking. With this, I would say you need to pick up the pace, and you need to make sure that you keep kidney diseases at an arm's distance at bay. Thank you, everyone. Wish you all good health. Thank you, Dr. Aggarwal, for being here on the show. It was a pleasure to have a person of your depth of knowledge, eminence, prominence, researcher, academician. Thank you so much.